Now, renal dysplasias occur when there's obstruction of the kidney that leads to damage to the renal parenchyma. And there are two types of renal dysplasia. The first type occurs when the obstruction to the kidney occurs after 10 weeks gestation, or when the obstruction to the kidneys is incomplete. And this leads to a dysplastic kidney that may have a thin echogenic renal cortex and may or may not have hydronephrosis. This is very different than the multicystic dysplastic kidneys that develop when there is early obstruction to the kidney that's complete. So if the obstruction to the kidney is incomplete, you may have a thin echogenic kidney, and if obstruction is complete and early in gestation, it'll be a multicystic dysplastic kidney. This fetus has renal dysplasia and hydronephrosis due to bladder outlet obstruction. You can see that both kidneys are markedly dilated with severe hydronephrosis, and you can see that the cortex around the kidney is very thin and very echogenic, and this is a clue that these kidneys can no longer function. On the clip, you get a better idea of how thin and echogenic the cortex is for each of these kidneys. Well, I mentioned earlier that ureteropelvic junction obstruction does not typically lead to renal dysplasia. In a few cases it does, and here's one such case. This is an 18-week fetus who had a normal kidney on one side and a dilated kidney on the other. This kidney had a dilated renal pelvis as well as dilated calyces, so the diagnosis of ureteropelvic junction obstruction was made. When this fetus came back, however, the right kidney was no longer hydronephrosis and no longer normal in size, but had shrunk in size so that there was very thin residual cortex and still dilatation of the central collecting system. As you can see, it was much smaller than the normal left kidney that was not obstructed. When a multicystic dysplastic kidney develops, instead of seeing a kidney in the renal fossa, you see a large multicystic mass. Typically, this is a unilateral process, but when it's bilateral, it is unfortunately incompatible with life because the fetus develops in the absence of renal function and thus cannot replenish the amniotic fluid, so it's surrounded by severe oligohydramnios. Here's an example of a multicystic dysplastic kidney. You can see on the transverse view of the fetal abdomen, you have a normal kidney on one side of the spine, and on the contralateral side, you see a large multicystic mass replacing the normal kidney. This mass contains multiple cysts that do not communicate with each other. On the longitudinal view, you can see that multicystic mass. You can see how it's much bigger than a normal kidney would be and has very little residual parenchyma. Now here's a fetus who developed a multicystic dysplastic kidney from a ureteropelvic junction obstruction. You can see that at 18 weeks gestation, there was a dilated renal pelvis to 6.6 millimeters, and there were dilated calyces, so this was a hydronephrotic kidney. When the patient returned for a 36-week follow-up, the kidney was no longer hydronephrosis, but had been replaced with multiple cysts and almost complete destruction of the renal parenchyma. Autosomal recessive polycystic kidney disease is a disease that affects the kidneys such that there is severe renal failure, and these fetuses may develop hepatic fibrosis. The severity of the disease in utero and shortly after birth depends on the degree of renal involvement. What we see on ultrasound is that we see enlarged echogenic kidneys. Because these kidneys are typically non-functional, there will be severe oligohydramnios, and we are often unable to identify any bladder because there's no urine to fill it. Here's the typical appearance. This is a longitudinal view of the fetal abdomen. You can see that there is no amniotic fluid around this fetus, and on either side of the spine we see markedly enlarged echogenic kidneys. Now they do retain their reniform shape, but they are much more echogenic than you would expect to see and much larger than you would expect to find. This fetus also has autosomal recessive polycystic kidney disease. In this case, you can see some of the tiny cysts in the kidneys. You can see how big each kidney is. You can see that this kidney on this side of the spine extends about halfway across the abdomen. The kidney on the other side extends almost from the back of the abdomen to the front of the abdomen. Notice there are lots of little cysts throughout these kidneys. This fetus also had a cyst in the liver. This is not an uncommon finding in these fetuses. They can have hepatic cysts, splenic cysts, even pancreatic cysts. Now, Meckel-Gruber syndrome does have polycystic kidneys, but also has some other anomalies that allow us to detect that this is a syndrome and not just polycystic kidneys. These fetuses also have encephaloceles, they have polydactyly, they often have cardiac anomalies, and as with polycystic kidney disease, they often have liver cysts. They may also often have a cleft palate. So here is a fetus with Meckel-Gruber. You can see in the view of the abdomen that the almost entire abdomen is filled with very large echogenic kidneys with cysts. So these are the polycystic kidneys. When we look at the clip through the hand, we can see there's polydactyly with an extra digit on one side. Here's the thumb, here are the forefingers, here's the extra digit. And when we looked in the head, we saw an encephalocele with protrusion of intracranial contents outside of the cranium. Here's another case of Meckel-Gruber. You can see the kidneys here are mildly enlarged and quite echogenic. You can see that the hand has 6 digits instead of 5, and the foot does as well, so there's polydactyly involving both the hands and the feet. Now, autosomal dominant polycystic kidney disease typically does not present until someone is an adult, but occasionally we will see indications that a fetus has autosomal dominant polycystic kidney disease. We may see a few cysts. You know that with adults the findings are hypertension and renal failure and multiple cysts, so some of those findings we might see in utero. We might see enlarged kidneys, we might see a few cysts, but typically these fetuses still have normal renal function, so we'll have normal amniotic fluid and the urinary bladder will be present. So here's a fetus with autosomal dominant polycystic kidney disease. You can see in scanning through the fetal abdomen, the kidneys are extremely echogenic. They're not enlarged and they do retain their reniform shape. On longitudinal view, you can see the echogenic kidneys, but normal reniform shape on each side. There also was normal amniotic fluid around this fetus. When we see echogenic kidneys, we don't always know the cause, but we do need to consider the differential diagnosis, which I've listed here. And the differential diagnosis includes obstructive dysplasia, as I showed you with the obstructed hydronephrotic kidneys from posterior urethral valves. Sometimes multicystic dysplastic kidneys look like echogenic kidneys. We also can have echogenic kidneys from genetically inherited renal disease, either autosomal dominant or autosomal recessive polycystic kidney disease. Echogenic kidneys can be seen with some genetic syndromes, such as Perlman or Beckwith-Wiedemann, or Meckel-Gruber, as we've discussed. Other causes include nephroblastosis, renal vein thrombosis, some toxic injuries, some infections, such as cytomegalovirus, ischemia, and aneuploidy. So here's a fetus who had an unusual appearing right kidney. You can see the right kidney, and we saw some echogenic areas within the central part of the kidney, as well as increased echogenicity of the cortex. When we interrogated with the Doppler, we discovered that this fetus had renal vein thrombosis that had tracked from the kidney into the inferior vena cava. Renal cysts are uncommon in the fetus, but not unheard of. They can be an isolated finding or an early sign of dysplasia. So here is a fetus who has a renal cyst in the upper pole of the left kidney. Here's the kidney. Here's the small cyst next to in the upper pole of the kidney. You know it's the left kidney because it's posterior to the stomach. And here we see on the clip that it is an isolated cyst, and the rest of the parenchyma appears normal. Here's another fetus with a large renal cyst extending off the lower pole of the right kidney. Here's the kidney, here's the cyst, here is the kidney here longitudinally with the cyst extending off the lower pole. The most common mass to find in the kidney of a fetus is a mesoblastic nephroma. This is a hamartoma. It's not a malignancy. It's more common in male than female fetuses, and it appears as you expect it would as a mass in the renal fossa taking up some or all of the kidney. Here's a case where the mass completely replaced the kidney. This is a transverse view of the fetal abdomen. The spine is over here, and you can see a well-encapsulated solid mass in the position of the normally placed kidney. This was a mesoblastic nephroma. Because it does retain its renal capsule, surgical excision is fairly simple. Here's another mesoblastic nephroma. You can see on a longitudinal view of the kidney, there's an echogenic mass occupying most of the upper and mid pole of the kidney with a little bit of residual normal renal tissue. Here again, you can see a little bit of residual normal renal tissue. The rest of the kidney is replaced by the solid mass. Here it is on fetal MRI. You can see the large mass occupying most of the left kidney with a little bit of residual renal tissue inferiorly. And here it is a pathology, large mass, little bit of normal tissue.